No worries. Okay, so let's get this rolling. Can everyone see my screen okay?
Yes, we can.
Yes, okay. So before I start, I'd just like to say thank you very much for having the opportunity to present today. And the first topic I'm going to be talking on is the 30-day mortality of patients presenting to the emergency department with substance-induced psychosis. As Neil mentioned, my name is David Barbic. I'm an emergency physician at the University of British Columbia and a scientist at the Center for Health Evaluation and Outcome Sciences in Vancouver. These are my co-investigators. I have no conflicts to disclose, and I'm very fortunate today to be talking to you from the traditional unceded territory of the Squamish Nation and Coast Salish peoples here in British Columbia. So, substance-induced psychosis is a common presentation to Canadian emergency departments and emergency departments across North America and around the world. Unfortunately, the largest data set that exists to this time is about 340 patients from a pan-European registry from about 10 years ago. And there's certainly no data on the outcomes of these patients and how they do, not just in the emergency department, but down the road. So we created a multi-center retrospective records review. We looked at consecutive patients identified in our ED database, and we had trained research assistants conducting standardized chart reviews. And our case definition for substance-induced psychosis was either amphetamine intoxication plus one of these key points, disorganized thought, bizarre behavior, delusional behavior, or a diagnosis of psychosis NOS with one of these following key criteria. This is a definition that has been used previously in emergency department research with regards to substance-induced psychosis. And one of our, two of our investigators are psychiatrists, and they reviewed these criteria and felt they were appropriate prior to starting. So during the span of our study, we were able to enroll 520 patients, and the median age, as you can see, majority were male. And partly due to bed block and access issues, and partly due to the way we manage these patients in our department, the length of stay was approximately 13 hours. The predominant substance of choice of abuse or use was amphetamines for this patient population. We do not have a high use of crack cocaine in our jurisdiction. And as you can see, fentanyl made up about 10% of the reported drugs of use. Of the patients we enrolled, interestingly, only about 1/4 required physical restraints. And the median time for this restraint application was about 100 minutes. 2 patients were admitted to the ICU on the index visit. 1 patient was with a hypoxic respiratory failure event secondary to aspiration pneumonia. And the second patient was with a massive upper GI bleed. We conducted a logistic regression controlling for age, amphetamine use, and ICU admission at the index visit. And fentanyl was associated with an increased risk of mortality. Notably, 1% of patients were not alive at 30 days, which we found actually quite surprising, quite startling. And this data around fentanyl, interestingly enough, it kind of correlates with what we've seen on a local level and has been observed on a North American level with regards to a huge spike in deaths related to the opioid supply and the stimulant supply being contaminated with fentanyl. We've seen a huge uptick in fentanyl deaths in the last 4 years here in British Columbia. So a lot of these patients are using polysubstance, and this is probably what puts them at risk of exposure to fentanyl. So as I said, probably be fairly succinct for this first talk. 1% of our patients presenting to the ED with substance psychosis weren't alive at 30 days. This is somewhat preliminary data. We've been able to collect an additional 300 patients in this data set, and we should have full results within the next little while. We've also looked out at 1-year mortality. For this patient population, we've explored a bunch of other key outcomes for this patient group, and more will come soon. The use of fentanyl in this patient population, as I mentioned, is associated with a markedly increased likelihood of death at 30 days, which really, unfortunately, shouldn't be surprising, but certainly presents us with an opportunity for intervention and improved care for this patient population. So I'd like to thank everyone for their time, and happy to answer any and all questions.
Thank you, Dr. Barbic. There are no questions in the chat, but do people have questions they would like to voice at this point? So I have a question. The 30-day mortality was identified with linkage with vital statistics in your abstract. Is that database unique to each state or territory in Canada?
Yeah, different provinces have different methods for linking vital statistics to clinical data. In our jurisdiction, we have the ability where our vital statistics is linked back into our EMR on a weekly basis. And so when we went back through all the patient records, we were able to see their date of death. And very often we were able to ascertain cause of death, but not all the time.
Okay. In theory, if a patient was seen in your ED in British Columbia and then died in Quebec, would you know?
Unfortunately, no. And that is part of the challenge, especially with this patient population, as you're alluding to, is that it's a very transient and marginalized population. So there is a possibility that we don't have an accurate representation. Unfortunately, what we do know is that there's sort of a funnel effect with regards to substance use and marginalized patients presenting to British Columbia, because our climate is fairly similar to Seattle, and it's a lot easier to be homeless or marginally housed here than it is in, say, Montreal or Toronto, where winters are -30, -40. So generally speaking, patients will sort of make their way west, and once here, don't tend to leave, or if they do, it's only when they get out of the horrible cycle of addiction and marginalized housing.
I have a quick question about the choice of the target group. Was there a reason you chose substance-induced psychosis and not substance-induced whatever, like any kind of substance-related visit, intoxication, or withdrawal, or other aspects of substance abuse?
Yeah, great question. Yeah, so colleagues of mine have been working on a provincial level looking at our 30-day and 1-year mortality post-opioid overdose presentation. And they just published a paper in CMAJ Open looking at that, and they showed that about 5% of patients presenting with an opioid overdose will be dead at 30 days, which is pretty staggering, tragic numbers. This, as I sort of alluded to, this substance-induced psychosis subset is such a understudied and understood subgroup of substance use. And unfortunately, we see a large number of substance-induced psychosis at my particular hospital. And it certainly presents a fertile opportunity to understand what's going on and provide better care.
Great, thanks.
Any other questions for Dr. Barbic? We have a quiet group today.
There will probably be more for the next session. Go ahead
with your second presentation.
Yes. Okay. Bear with me one second. Okay, everyone's able to see that okay?
Yes, thank you.
Okay. Okay, so today I'm very fortunate to be presenting on this topic, rapid agitation control with ketamine in the emergency department, a randomized control trial. As I've already introduced myself, I won't go through that again. I have no conflicts to disclose. and I've already acknowledged the lands from which I speak today. So we all see these patients on a daily basis, agitated, potentially violent patients presenting to the emergency department. And we all know that rapid control of psychomotor agitation and potentially violent patients is really important, not just for their safety, but for ours. And we hypothesize that ketamine may provide a rapid, effective option with regards to behavior control and sedation. So we conducted a randomized controlled trial of intramuscular ketamine to a combination of intramuscular midazolam and haloperidol for this objective. This was a single center study. We conducted a parallel arm, double-blind, 1-to-1 randomized controlled trial comparing 5 milligrams per kilogram of ketamine to a combination of midazolam and haloperidol, 5 milligrams each. Just to qualify, this combination of sedation was chosen after a survey of regional emergency physicians. Our planned enrollment was 184 patients. Unfortunately, our trial was stopped early due to a moratorium on in-person research due to the COVID-19 pandemic by our local research ethics board. We used a randomized block design of 2, 4, 6, or 8 created by our study statistician prior to study commencement. Our primary outcome was time to adequate sedation as defined by a Richmond agitation and sedation scale of less than or equal to -1. And our secondary outcomes included the need for rescue medications, serious and adverse events, and incidence of NMS. This is our consort flow diagram for the trial. We assessed 308 for eligibility, 81 were randomized, 41 to the midaz haloperidol group and 40 to the ketamine group. And in our final analysis, we had 40 in the midazolam haloperidol group and 39 in the ketamine group. These are the characteristics of our enrolled patients. As you can see, the ages were fairly similar, as were gender distributions. The one thing to note was actually that the group, by chance, the group receiving ketamine seemed to have an initial RAS score which appeared to be a little bit higher, just by chance. And the relevant comorbidities and initial vital signs are listed here. So we used a adjusted Cox proportional hazards regression controlling for age, gender, and initial agitation score to examine our primary outcome, which was the time to sedation. And ketamine group was observed to have a higher proportion of adequately sedated patients at each time period throughout the course of the 30-minute observation window for this trial. We described the serious adverse events that we observed in our trial here. There were 5 in the ketamine group and 2 in the haloperidol midazolam group. None of these patients required endotracheal intubation or admission to the intensive care unit. The patients that experienced apnea or required supplemental oxygen resolved with simple bag mask ventilation or application of face mask. And the one patient experiencing laryngospasm in the ketamine group resolved with a brief period of jaw thrust and airway repositioning. So in conclusion, for a select group of agitated patients, intramuscular ketamine can provide faster sedation compared to a combination of midazolam and haloperidol. In our study, adverse events were similar between groups, but we do acknowledge that our study was probably underpowered to comment definitively with regards to safety and adverse events. Thank you very much for your time and very happy to answer any questions.
Questions for Dr. Barbic?
If you had the choice, which one would you use next time you see an agitated patient?
Great question. I I think for a severely agitated patient that is not amenable to redirection or verbal de-escalation and that is requiring intramuscular sedation, I think for me in a monitored setting, ketamine is the way to go.
Yeah, I think a lot of people probably feel that way, but I was kind of taken by your adverse events because typically I would think there would be fewer adverse events that I'd be concerned about the ketamine versus the alternative, and for decades now we've been comparing various medications against that combination of something like midazolam and haloperidol, and almost every time we look at it, we find that even straight up benzos work. So it's like this is a kind of theme that we've been facing in the field for a very long time. Yet still we persist in using the old school haloperidol, despite the fact that we know it leads to other problems.
For sure.
So I'm just kind of struggling with with why we keep doing it and why we keep finding other things work just as well or just as good or better, yet we still do the old stuff. Any thoughts on that?
A great question and great segue. Yeah, so I mean, a big reason why this trial came about was, as I alluded to in the earlier presentation, we see a huge number of agitated and violent patients in our emergency department. And we had some fairly notable M&M cases with regards to sedation bundles. And it is not uncommon in our department to have to give someone a total of 20 or 30 milligrams of midazolam and 20 or 30 milligrams of haloperidol to gain some element of control. And then, of course, all the badness occurs. And so this trial was born out of seeing some of those cases and reviewing some of those cases, and sort of a building body of evidence from the pre-hospital literature and the emerged literature that showed these prospective series and prospective cohorts that ketamine may be beneficial. It should be noted that we don't have enough sample size to really comment on the safety of ketamine, and other studies that have been bigger yet non-randomized have seen higher adverse event rates. I think that's sort of the area for future research, whether there's a multi-center study or a larger single center study. That remains to be seen, but hopefully this can sort of aid clinicians with regards to providing better, safer, expedient care for this patient population when I think the temptation sometimes can be sedate and walk out of the room. And being able to do that quick physical exam, pull labs, get imaging within a few minutes of them coming in is so important. Just my little soapbox.
Dr. Barbic, there's another question from Dr. Larkin, which the question is, how did you manage consent for this trial?
Great question. So our local institutional review board authorized a waiver of an informed consent because from pretrial data, the vast majority of these patients end up getting what we call certified under our local mental health act, local mental health legislation. And they lack the capacity for informed refusal of care, and they're very often intoxicated with substances. And there's no substitute decision maker present. So we worked with our local bioethicists and were able to sort of satisfy the requirements for our local REB.
I just had one comment. I thought this was clearly looks like ketamine works much faster, which is not surprising, but it also wears off faster. Typically, IM within about 30 minutes versus Haldol lasts longer. So I think it means that you probably had to be prepared fairly quickly to redose patients if you're starting with IM ketamine to get them down. Does that make sense?
I think that's a very accurate observation. Our median time to sedation was 5.8 minutes for the ketamine group and 14.7 minutes for the midazolam haloperidol group. And that's pretty consistent with pre-existing literature with regards to the time of onset. outside the realm of this study, I've observed patients who ketamine, you gain control for 45 minutes. And then in some of our very, heavy polysubstance using patients, it might last 20, 25 minutes. And so getting IV access, pulling your labs, and having adequate post-ketamine sedation ordered is, I think, an important part of the overall care for these patients. But it allows you to keep your staff safe and keep the patient safe in the first few minutes of their arrival.
Any other questions for Dr. Barbic?
Thank you so much for the opportunity to present today.
Thank you very much. Very nice work. Next up, we have Dr. Ed Boudreaux from UMass. And Dr. Boudreaux, take it away.
All right, you guys can see my screen?
Yes.
All right, I'm going to talk today about the ED-SAFE-2, which is a study evaluating sustained universal suicide risk screening and detection in emergency departments. This is funded by the National Institute of Mental Health, and I have no disclosures. This is the author team, and I really want to thank Dr. Celine Larkin, who's on the call today, for her contributions completing this study. We're going to review the rationale for why emergency departments are appropriate settings for universal suicide risk screening, and we're going to review the results from the ED-SAFE-2's pragmatic clinical trial evaluating sustained screening outcomes. I'm going to start with the conclusion. Using a continuous quality improvement strategy, it's feasible, although challenging, to implement and sustain universal suicide risk screening for patients 18 and older in the ED setting. Improving screening leads to improved risk detection, which is, of course, what we want. We demonstrated that that was true. But this dips a little bit long term. So you kind of have a little bit of a spike and then a bit of a drift after you implement. The other thing we notice is that site performance varies widely. Now we're going to go into the details. Why is it important? Because we've shown, and others have shown, that suicide risk is often not detected in emergency department patients. The emergency department is one of the most suicide risk enriched environments in the entire healthcare system. And based off of what we've shown through many studies, during usual care, if you're not screening systematically, you're going to miss a large proportion of them, maybe even most of the patients who have suicide risk, who are going to go on after the ED visit to either attempt to kill themselves or to die by suicide. That's why it's important. We demonstrated in the first ED-SAFE pragmatic clinical trial using 8 emergency departments spread out across the country, the United States, that you can indeed integrate universal suicide risk screening into routine clinical care. These were all large to medium emergency departments. Some of them were community-based emergency departments. Some of them were large metropolitan academic emergency departments. But you can see over the course here, we started in the control condition or treatment as usual all the way to the left of the graph. On average, about 26% of those patients were being screened when we started. We implemented universal screening using a CQI process. It increased to around 73%. We continued with our cycles over time, and we ended up with an average in the last phase of the study of about 85% of all the ED patients within those ADDs being screened for suicide risk. So you can see that was a pretty big jump, both statistically and clinically significant. And what happens whenever you do that? Well, you end up detecting increased risk. So the proportion of patients being seen in those ADDs in the treatment as usual control condition, about 2.9% of those patients were identified as having suicide risk during routine clinical care. And by the end, with the increased screening, we found that at 5.7% were positive. So we almost doubled the rate of detection of suicide risk by screening. So all those patients that I mentioned earlier who were not being detected with routine clinical care, when we start to screen, lo and behold, we actually start to identify those patients. Actually, one more thing, what I mentioned earlier, you can see these are the plots of the individual sites. You can see that here they're pretty clustered closely together in terms of detection. The same thing was true in terms of the screening rates, but over time you see a much larger disparity or a variability within the sites. So when I mentioned earlier the conclusion that the sites actually have a lot of variability. That's what you see here in this time series graph. So what happens when the grant goes away? So a major objection to our first study was that, well, sure, you got millions of dollars to get people to do this screening. What happens whenever the grant goes away? And there's plenty of evidence in other areas that that's a very important question, that when the resources to support and sustain this effort actually go away, then so too does the performance gains. So you can think of this way back in probably your intro psych class. You talked about the Hawthorne effect, where when people are observing people, they do better. When you stop looking at them and stop observing them, they go back to their normal performance. So EDSAFE 2 helped to answer this question. So you can see here, the first part is the screening data that we presented earlier. And here, after the grant was discontinued and everything was kind of dismantled, we went back on average about 8 months after the grant ended to look at what those screening rates were by evaluating the charts, randomly selected charts in those emergency departments. And you see that the screening rate actually stayed pretty much the same. So the last phase of EDSAFE 1 was 85%. The first and the fallow period, or the follow-up period where there was no grant, stayed at around 89%. So that was pretty encouraging. The detection rates associated with that were roughly the same. So they were in the same territory. So 5.2% when we first started the implementation, 5.7% at the end of EDSAFE 1. And then in that fallow period after the grant ended, it was around 5.2%. That was actually a statistically significant drop. We had a pretty large sample size here. So it's a statistical dip. You can kind of evaluate on your own whether you think 5.7 to 5.2 is significant, but it still remains significantly greater than baseline. So much of the increased detection remained. So what happens when you reinvigorate the activity by focusing on screening again? Because you figure, well, maybe that drop was because people were just documenting the screenings as having happened, but weren't doing a good quality screening. So we did notice this when we did our fidelity interviews. I didn't report this data, but we have some data that suggests that documentation of screening was happening when the screenings actually weren't getting done. So we really tried to focus on that so that people would stop documenting screenings that actually hadn't gotten done and actually do more high quality screenings. So this is the two more additional phases. So this is that baseline phase I already showed to you, and this is the implementation and maintenance. In other words, these are two additional phases we added into EDSAFE 2 to see if we can improve the quality of the screening. The screening rates were roughly the same across those. What we were really looking at is whether we could drive up that detection rate by doing better quality screenings. 5.2% was where we were, as I mentioned earlier, but in our follow-ups, it basically stayed the same and actually dropped a little bit more. So now it's 4.8%. Remember, the high was 5.7% at the end of EDSAFE 1. So, basically, how do we understand that we maintain the screening rate? So the screening rate stayed high, right in the middle 80%, but the detection rate was dropping over time. So that's a difficult pattern to describe. So here's some hypotheses. The risk in the population might actually be dropping. So even if you screen everybody, if the risk is dropping, you're going to get a lower detection rate. Seems unlikely that this is what's happening when you consider epidemiological trends that show increasing rates of suicide and suicide attempts over time, over the same time period. It could be that the fidelity to the screening is dropping. So they're just charting that they're doing the screening. So it looks like they're screening, but they actually haven't been doing the screenings, even though we focused on trying to get them to do it. So this was something we were really paying attention to. We have measured that this fidelity rate, is a problem in many EDs. So it does happen. So it could be that the fidelity to the screening was just not being very good. And so we dropped in our detection rates, or it could be some combination of both of these factors that are at play. So I'm going to go ahead and stop there. I have some more statistics I can show, but that's the gist of what we found, and I'm open to questions.
There's nothing in the chat room. Anyone have questions for Dr. Boudreaux about this excellent work?
Ed, I got to commend you. I love this work that you're doing with regards to EDSAFE and the suicide screening, and I've admired it from a distance for a while. I guess my question is, given some of the hard lessons you've learned, what would you recommend are some of the key things in terms of actually getting this implemented and advocating for this change at a system level, whether it's locally, regionally, statewide, nationwide, whatever, because there's a lot of hesitancy both on the part of clinicians and on the part of administrators to do something more, do something extra. And you've obviously learned a lot of the hard lessons.
Yeah, well, I would say that if you're interested in doing universal screening and trying to make the argument that it's effective, you have to think about two things. The first thing is we didn't show that our universal screening broke these emergency departments, which is what everyone was afraid of. People in these EDs, believe me, there was a huge, tremendous resistance when we started this. Everyone was afraid that when we started to detect these new cases, that it was just going to literally bring everything to a grinding halt. That's what everyone was concerned about. But we showed that that didn't happen, that even though we did increase the detection, so that part happened, the detection of that risk was generally in the mild to moderate range, and they didn't significantly increase the number of psychiatric evaluations. So when you put this into place, you do have to figure out how you're going to handle those new detections. And if you require a full psychiatric evaluation for every new case, then it is going to break the ED. You have to create a more balanced and reasonable approach to patients who aren't imminently suicidal. And as long as you can do that and come up with something that's reasonable, like most of these emergency departments simply provided additional behavioral health outpatient referral resources, or maybe some of them had like a social work evaluation, or what we call a psych light evaluation. So it wasn't a full eval. It wasn't, what you normally would think of as a psych eval. So if you can pivot and come up with an approach that's what I call strata sensitive, so it's not treating every patient who has any suicide risk the same, I think it becomes way more realistic to be able to do this. And in fact, it's necessary, because there's no way if you're going to almost double the rate of detection and you're going to now try to do a full psych eval on every single one of those patients the same way you do now, that you can sustain it. It is going to break the ED. So that's a legitimate fear. So you have to come up with something that's right sized for the risk. We do it for all kinds of other medical disabilities. You don't get a cath lab on a cardiac catheterization on every patient who comes in with chest pain. You come up with a stratified approach. Some of those you might eventually, but you realize they're kind of in that moderate risk range, and you discharge them to a high risk clinic, and then they make those decisions then. So there's all kinds of flexibility we've built into dealing with other problems. If we do that with suicide, I think we can manage the increased risk detection.
Other questions for Dr. Boudreaux?
Dr. Boudreaux, I have a quick question for you. Nice to see another UMass person on here.
Hey,
so how are you? So I'm curious if you're planning to implement this in the pediatric emergency department, and how you plan to mitigate kids that might just be having a bad day or not really understand what you're asking, and those who are truly acutely suicidal.
Yeah, that's a great question. We've already implemented it at UMass in the pediatric ED. This is the ED Safe 2 studies that I just presented, but we have a third study called the System of Safety, which is a zero suicide implementation study. And we implemented universal screening 12 years and older. So we currently in the UMass ED and all the EDs actually in the UMass system. So there are 5 emergency departments in the UMass system. The screening for children 12 to 18, depending on defined children, that's how most of us define children, is currently happening. And so the challenge is, first off, you address some of the developmental problems by focusing on 12 and older. You get the younger you get, the more difficult it is to screen children. So 12 and up, and we do the screenings, and people have to use their own judgment as to how they're going to do that. The younger they are, the more clinicians generally will adapt the questions, and the more they will rely on collateral report. So people who are with the child, the older they are, older teenagers, they understand the questions. And so you basically ask them the same way. One of the reasons why we try to standardize the wording is so that people do ask the same question, you know what you're getting. Because things like you guys are all familiar with, the domestic violence screener, do you feel safe at home? That's what we all use. It's a terrible, terrible screener. It does not detect domestic violence. It detects all kinds of other stuff, but it's really not very good. So if people are asking questions like that for children, especially, then they're going to get even worse results because the interpretation of what that means is still variable. So we do think standardization of the questions is important even with children, but you do have to use some judgment to modify if they're young enough that they probably won't understand the questions.
Thank you, Dr. Boudreaux.
You're welcome.
That's wonderful work. Next, we have Dr. Celine Larkin, also from UMass.
Can you guys see my screen okay?
Yes, we can.
Great. I'm really happy to be here today. It's my first SAEM, so happy to be here and have some other UMass colleagues here as well. So today I'm going to present on a different study to what Dr. Boudreaux covered. So this is data from the clinical decision rules study, which is also an NIMH funded study. And we were taking a slice of data to look at sexual and physical abuse history in emergency department patients, examining risk factors and their associations with suicidality. So I gratefully acknowledge my co-authors on this study. We don't have any conflicts of interest to declare, and the study was funded by the NIMH. So survivors of childhood sexual abuse are significantly at risk of a wide range of health problems. So spanning obviously psychiatric problems, so more psychotic symptomatology, depression, anxiety, dissociation, eating disorders, but also some psychological impairment as well, and physical health problems too. So these are a variety of negative health outcomes that were identified in a systematic review from Hales and colleagues. And similarly, another systematic review found increased risk of a range of poor psychosocial outcomes, psychiatric diagnoses, and physical health outcomes among survivors of childhood sexual abuse. And the same is true of physical abuse. So having a history of physical abuse places individuals at increased risk of future depressive disorders, drug use, sexually transmitted infections, and risky sexual behavior. In addition to these broader health outcomes, there's a relationship between having experienced sexual and physical abuse and experiencing risk of suicidal thoughts and behaviors. So according to a number of different systematic reviews, we see high risk of suicide attempts among those who have experienced physical abuse, so up to 3 to 3.5 times more likely, and same with sexual abuse, so an increased risk of suicide attempts of survivors of sexual abuse as well. So why do we think that that might be the case? So one thing that we can do is look at some of the, etiology of suicidal behavior from the literature. So this is a well-regarded model in the field. It's the interpersonal theory of suicide, and it suggests that individuals who end up, making suicide attempts and dying by suicide have this interaction between thwarted belongingness, so feeling that they are very alone, a perceived burdensomeness, so feeling that they are a burden on the people around them, and then also having capability for suicide. And that's what makes a person translate from thoughts of harming themselves to actually engaging in suicidal behavior and making a suicide attempt. So this is kind of a trans-diagnostic model of suicidal behavior. So regardless of what the psychiatric diagnosis is, this is a model that can explain and predict suicidal behavior. And so when we think about how experiences of abuse might interact with some of these things, people who have experienced abuse have a sense of disconnection and distrust that could really exacerbate that thwarted belongingness. They may also experience self-conscious emotions like shame and guilt that can lead to a feeling of perceived burdensomeness. And then having been, exposed to violence and having experienced that can actually increase their capability for suicide, in which their relationship with their own body is different from, other people's. So that kind of capacity for self-directed violence is increased. So that's sort of a theoretical understanding of how sexual and physical abuse might increase the risk of suicidality. So our aim in the current analyses was to examine the prevalence and risk factors for sexual and physical abuse in emergency department patients and examine their effects on suicidality. So the analyses are part of a larger study that's aimed to derive a clinical decision rule for suicide-related care in the emergency department. So this is kind of a slice of data from that larger study. And to date, when we pulled the up to the date where we pulled the data, we had approached 1646 patients. Over 1,000 had refused and 135 were ineligible. 434 agreed to participate and 359 completed the entire assessment. So that's a range of indicators, self-reported indicators and clinical questions as well. So we have a variety of chief complaints within this group. So we wanted to have a more risk saturated population. So we do have an overrepresentation of psychiatric chief complaints in the sample. So we assess a range of psychological and social risk factors, and specifically abuse was assessed with 2 questions. So have you ever experienced physical abuse and have you ever experienced sexual abuse? And so we didn't operationalize what that meant. We asked this question and then patients were allowed to answer how they understood that term to be. And we assessed suicidality with the Columbia Suicide Severity Rating Scale. We conducted 2-sided chi-square and logistic word depression analyses. So just to start by looking at the prevalence of physical and sexual abuse in our sample. So sadly, over a quarter of the patients with medical chief complaints had experienced one or other type of abuse, and over 2/5 of the psychiatric sample had experienced physical and sexual abuse. So sort of interesting patterns by chief complaint there. And actually, when we looked at people who had experienced both types of abuse, that was almost a quarter of our sample had experienced both types. And if a person had experienced one type, they were more likely to experience the other as well. There were several factors that were associated with abuse. So female gender was associated with sexual abuse, as was chronic pain, having a mental health diagnosis, being withdrawn, self-disgust, recent passive suicidal ideation, lifetime active suicidal ideation, and lifetime suicide attempt. When we looked at the factors associated with physical abuse, we found that female gender and Hispanic ethnicity were significantly associated, as was living alone. And then the last 6 variables as well that we saw on the sexual abuse analyses. So experiencing either type of experiencing either type of abuse independently increased the risk of suicidality. So most of those with an abuse history had a history of thoughts of killing themselves. So 2/3 of those with an abuse history had thought about killing themselves, which is a really high prevalence compared to what we see in the general population. And almost half of those who had experienced abuse had attempted suicide at some point. So again, this is way beyond what we would see in the general population and even in the ED population, as you could see from Dr. Boudreaux's slides earlier about the prevalence of lifetime attempt in this population, which tends to be somewhere between 10 and 15%. After controlling for mental health diagnoses, we still saw a relationship between a history of abuse and both lifetime suicidal ideation with an odds ratio of 3 and lifetime suicide attempt with an odds ratio of 3.7. So really increased risk here that's not explainable by the psychiatric diagnosis. So just a word on limitations. So our questions on abuse did not define what was meant by that. So it was up to the patient to, sort of define what they understood to be physical or sexual abuse. The sampling that we used was consecutive for the psychiatric patients and randomized for the medical chief complaints, but participation was obviously self-selective because they do consent to take part and many patients refused. Experiences of abuse are associated with a constellation of psychosocial risk factors, and both types of abuse were significant risk factors for suicidality in our sample. So I just urge clinicians really to carefully consider the broader psychosocial well-being of patients who report experiencing either sexual or physical abuse. Even if they're presenting with a medical chief complaint, they are still at increased risk of these psychosocial negative outcomes and suicidality in particular. So thank you.
Thank you, Dr. Larkin. That's excellent work. There is nothing in the chat room. Questions for Dr. Larkin? From anyone? Dr. Larkin, can you comment on the 1,077 patients that did not agree to participate. What is your general sense? Is your general sense that they actually are not at risk, do not have a history of physical or sexual abuse, and therefore were not interested, or was it too difficult to participate? What is your sense?
Yeah, so I think because the broader study is more focused on suicidality, really the abuse question is not something that they are aware of, explicitly before they participate. So I don't think that was why they refused. I think part of it is just people are in the emergency department, they're unwell, they don't really have the patience to sit with a research assistant for a significant kind of, number of questions about their history and that kind of thing. So I think that's an issue. I think that we will be able to look at the differences between those who participated and those who didn't later on in the study when we're able to compare, because we do have demographics on people who refused to participate. The other thing is within the larger clinical decision rule study, there is a follow-up requirement. So we are doing 6 months of phone call follow-up for those patients. So I think for some patients, just the level of involvement is a little bit too much for them when they're not at their best and at their most comfortable. So I think that's probably why we've had refusals. We do track reasons for refusal, so we'll have a little bit more data on that as well.
Okay. Any other questions for Dr. Larkin? Okay, thank you. Next we have Justin Fernandes, who is a medical student from University of British Columbia.
Can everybody see that? Okay. Let me just make this full screen. Okay. Great. So hi, everyone. Thanks for having me today. I'd like to first thank the Society for Academic Emergency Medicine for the opportunity to present. My name is Justin Fernandes. I'm a third-year medical student from Vancouver, British Columbia, Canada. So today I will be presenting on the topic of Canadian emergency physician attitudes towards patients who have attempted suicide. On behalf of our team, who is listed on this slide, my supervising physician is Dr. David Barbic, who you guys are already a bit familiar with now. So I have nothing to disclose. So just to sort of introduce this topic, the global conversation around mental health and mental illness has grown in recent years, yet the stigma associated with mental health concerns and suicide can still negatively impact patient experiences and quality of care. Unbiased, compassionate care is especially important in the context of the emergency department, as there does appear to be evidence that suicidal ideation is present in approximately 10% of adults who present to the ED, even if their chief complaint may be unrelated. So therefore, our objectives were to measure two things: emergency physician attitudes toward patients presenting with suicidal ideation, and the self-reported skills and training of emergency physicians to care for this patient population. So to evaluate these objectives, we designed a secure online survey and distributed it to attending physicians of the Canadian Association of Emergency Physicians, those who had consented to receive surveys from the organization. As part of this survey, we used the Understanding Suicidal Patient Scale, or the USP scale, which was utilized to assess providers' attitudes toward individuals presenting with suicidal ideation. So the scale is an 11-item questionnaire scored. Each question is scored as a 5-point Likert, with individual scores summed to provide a composite score. The lowest possible score is 11. The highest was 55. So this scale is a reverse scale, so that lower scores actually indicate higher empathy. In previous work, a score below 23 indicated a high degree of empathy, which is what we were going to use as a cutoff. So the tool has been validated in numerous healthcare populations, including nurses and physicians of various specialties, including emergency medicine. So the survey questions pertaining to perceived competency in treating patients with suicidal ideation were developed from a review of literature. We also collected some demographic data. So our primary outcomes were proportion of emergency physicians reporting a USP score less than 23, and then some descriptive statistics around this score. And then our secondary outcomes were self-reported physician skills for managing suicidal patients. Data were described using counts, means, medians, and interquartile ranges. So as for the results, the proportion of our respondents reporting a total USB score less than 23 was 52%. The mean USB score was 21.8. The median was 22 with an IQR of 18 to 25. The highest score that we received, which represents the lowest empathy, was 35 out of a total possible score of 55. And a histogram depicting the scores of all our respondents shows a skew towards lower scores. And this slide depicts our secondary outcome. So prior training of our respondents and their perceived competencies in treating patients with suicidal ideation. So interestingly, only 17% of respondents reported participation in training specific to treating patients with suicidal ideation in the last 5 years. So this could include residency training, this could include continuing medical education training, and so a very small amount of participants actually had this training recently. 64% of respondents believe they could screen patients for suicidality. However, as management became more complex, from assessing severity of suicide risk to counseling, and finally creating a safety plan, respondents progressively felt less confident in their skills. And only 30% agreed that they felt confident in creating a personalized safety plan for the patients at risk at suicide. So I guess to summarize and kind of conclude, Canadian emergency physicians generally have positive attitudes toward patients presenting with suicidal ideation. Our respondents' mean USB scores compare favorably with findings from other studies that utilize the USB scale, including practitioners such as general practitioners, psychiatrists, internists, and various healthcare providers working in emergency departments and mental health clinics, indicating a high degree of empathy from Canadian emergency physicians. Our study highlights a potential for improvement in managing patients with suicidal ideation. So Canadian emergency physicians felt they had the skills to adequately screen patients for suicidal ideation, yet reported a lack of confidence in providing other pretty key components of care for this patient population. So this may be due to the current curricula of emergency medicine, postgraduate training programs, and continuing medical education in Canada, which displays a concerning scarcity in training opportunities to provide emergency physicians with the necessary skills to care for this high-risk population. So our study illustrates a need for enhanced training and ongoing medical education in this area, and further research may focus on the utility of universal screening for suicidal patients, for suicidal ideation, and the efficacy of educational interventions for physicians. So some of the work that Dr. Boudreaux was speaking to as well. And then the chief limitation is a low response for the survey, which was 15%. However, our demographic data does roughly align with recent data from the Canadian Medical Association on emergency physician gender and age distributions, and has good sampling from rural and community practices, which may help to mitigate this bias a bit. As this is a topic that is already understudied in Canada, the low response rate may underscore the importance of our study in advancing this conversation. Suicidal ideation encompasses a broad spectrum of risk, and it is likely that emergency physicians may be more comfortable managing some patients with suicidal ideation than others. Thanks everyone for listening. I'm happy to take questions.
Thank you, Mr. Fernandes. There are no questions in the chat. Anyone have questions on this important topic? So I just had an observation, which is that 64% of the EPs indicated they had the skills to screen these patients, which means that 36% did not. To me, that's shocking. And I'm sure that if you did this study anywhere in the US and in other states in Canada, you would get very similar results. But I think that that means we have a long way to go.
Yeah, definitely. I think definitely part of the impetus for this was kind of looking at some preliminary work in terms of could we do more in terms of screening, and we definitely wanted to kind of set a baseline what was already happening, and I think this kind of helps toward that goal, basically. Yeah, so
it's great that the physicians had empathy for patients, which is obviously a great start, but they clearly over a third did not feel comfortable with their skills in assessing these patients, which is a high number.
Yeah.
And just speaking to Justin's point, I think our results roughly align with some of Dr. Boudreaux's and Dr. Camargo's previous work with regards to perceived skills and ability to care for these patients. So it's sadly not a thing that is unique to Canadian emergency physicians or American emergency physicians. It's probably a global issue, something that probably has to require ongoing intervention and study.
Yeah, I think that's.
I'm curious about what you guys think might be needed. So if you kind of think about people are the emergency physicians are saying that they don't feel they have the skills. I guess there's two paths that I've worked on, and I'm curious about your reactions. There's one path which is more traditional, where we have screening instruments that are already validated. The patient safety screener, for example, which is what we used in the ED Safe studies and have published on. Simple. It's it was designed with emergency physicians and emergency nurses to be as simple and trainable as possible, so that even if you didn't have a lot of training, you could use the instrument. It's got very clear boundaries and very clear scoring and stratification. Is that an option? Or another option is computerized versions. So you can do actually a much better job with computerized screening instruments, because they always do the right. They always are standardized. They don't they mess around with wording and they don't have inflections and all that sort of stuff. So we actually have good example with good experiences with computerized versions of screeners doing a better job than human beings. And in fact, this in emergency medicine, we've known this for a long time with domestic violence screening, stuff that Karen Rhodes did, years ago. So I'm thinking about those two options. One is training people on how to use a simple, I would say paper-based, but it's simpler in the EHR screening versus using a computerized screener. What's your thoughts on those?
Yeah, definitely interesting possibilities. Part of our survey, which I didn't include, they did in here, we kind of looked at what people were currently doing in terms of screening. We found that a lot of people were just using stuff like sad persons or kind of more like basic stuff and not really validated tools in their screening. So I definitely think it doesn't seem like there's a lot of knowledge around the validated screener. So definitely computer ones might simplify the process, might make things a bit easier in that sense. I'm not as familiar with some of the computerized models. I don't know too much about that. Maybe Dr. Barbic, you might be able to comment a bit more. Yeah,
I think Ed, you raised some wonderful points, and I think yes, that is probably the future. I think for me, at least personally, I mean, the screening is obviously an important part of this overall thing, but I think even more concerning is this our findings of the ability to provide counseling and safety planning, incredibly low rates of confidence and self-perceived aptitude. And I mean, just speaking from my own personal experience, a month of psychiatry during residency, suicidal ideation and sort of general mental health presentations are not a strong emphasis of a lot of the residency training that we receive. I don't know if that's a uniquely Canadian problem or if it's something that's an issue south of the border as well, but it's certainly, that part of it as well, I think is a big piece of the overall puzzle. So certainly fertile ground for improvements of care moving forward.
Yeah, I think about those other skills that you just talked about and who's most appropriate to provide them, like personalized safety planning, really finding good referral resources and connecting people to care. And frankly, it doesn't seem like the emergency physician and most emergency departments really is most appropriate. Like if you have access to other behavioral health or social work staff, they may be more appropriate to be able to deliver that type of care. The front part, the screening and assessment, I think is, from my, just my experience, I'm not an emergency physician. I think you guys know that. I'm a psychologist. I've worked in emergency medicine for a long time though. And I think those first two do fall within the scope of practice and the skill set that emergency physicians can learn and can master. They master it for a whole bunch of other problems, right? This is just one more. They don't get the training, as you mentioned. So it's more, even maybe perhaps more important to be able to develop tools that are easy to use and easy to train. I think the other stuff, personalized safety planning, counseling, that sort of stuff, the problem with it is everyone recognizes a behavioral health provider is probably better to do those things because it's more within their scope of practice and what they self-identify as being tools that they should be able to do. But then most emergency departments, probably including Canadian emergency departments, don't have access to those behavioral health professionals. So you're left in this, this really in a lurch where you don't have access to people who really could do and should do those things, but it's really also not in the scope of practice for most emergency physicians.
That's true, sadly enough. All right, thank you, Justin.
Thank you for the opportunity.
The last presentation is Marcella Jewell, who's a medical student at UMass.
Great. Hi, everybody. My name is Marcella. I am a first-year medical student at University of Massachusetts, and I'm going to be talking about the cost of boarding behavioral health patients. This work was done under the direction of Dr. Hetler, who's the chief of our pediatric emergency department here at UMass Bay State. So our title is Assessment of Behavioral Healthcare Costs for Pediatric Emergency Department Patients Using Time-Driven Activity-Based Costing. I have no financial disclosures to report. So the experience in our pediatric ED reflected well-documented national trends that really do highlight the pressing need to move the needle on alleviating the behavioral healthcare burden in our EDs. There's been a 2-decade-long trend of increasing behavioral health visits, which we're all probably familiar with, and long boarding times associated with poor outcomes. But more alternatives are suggested, but they're often thought to be a little bit too costly, or the cost is unknown. And since traditional costing methods rely only on care for which that are billed or well documented, we thought that traditional costing methods would likely underestimate the true cost of behavioral health care in our EDs. So since care is poorly reimbursed and traditional costing methods would likely underestimate the cost, it was our objective to identify the cost using time-driven activity-based costing, sometimes abbreviated as TDABC, at an academic pediatric ED with a yearly behavioral health census of 1,000. So our methodology employs this multi-step process that we followed very carefully with the assistance of our team at Harvard Business School and the founders of the methodology. And so the medical condition that we chose, which is essentially the inclusion criteria, was all non-acute behavioral health patients arriving to our PDED during a 2-week period in October with a chief complaint of anything related to behavioral health care. So we created this process map with PDED staff that detailed the care cycle for a typical behavioral health patient. So stage 1 was defined by the patient's arrival until they were medically cleared. Stage 2 was defined as the wait time until an ESP or our emergency service provider was able to begin the assessment. Then stage 3 was the time required for the entire ESP evaluation. And then stage 4 was boarding, or when the ESP made the disposition for the patient to either be discharged or go to an inpatient treatment setting until the patient was actually discharged from the emergency department. So we recruited a highly motivated group of pre-med students, which I know we have all been there before. That was me literally last year, to meticulously track the time required for our care team to complete each activity. And so the circle at the bottom of the corner of each box represents the average time to completion of each activity. I mean, the process is extremely detailed. For instance, we even tracked not only how often the patients had a sitter, but also the pay grade and the ratio of each sitter. So the process map does look a little complicated, but each color essentially represents a different care that was given, and the time was categorized as either direct patient contact or charting and administrative time. So I'm going to just geek out for a second because this is my favorite part of the process. So the next step was to calculate the cost of each resource and then assign that cost to each activity. So we'll first use this activity intake evaluation, and it's blue, and our nurses at Bay State wear this beautiful blue color. And so I'm going to give you a little overview of that. So each team member is assigned a method-specific term called the capacity cost rate, which is measured by the total expenses of that patient, salary, benefits, et cetera, over their available capacity to work, whether it's 40 hours a week, part-time, et cetera. So as you can see, The nurse took 11.7 minutes to complete this intake evaluation, and there are 3 capacity cost rates associated with this activity. So the first is personnel, which was $1.17 per minute for that nurse to work. And then second was the space cost. So that was basically the entire cost of the pediatric ED divided by the number of minutes in a year. So we were able to see, how much that space actually cost per year. And we worked with our engineering department to even look at like the exact square footage of the care space we have just for behavioral health patients. So in total, this one activity costs $35.48. And we have this granular information for all 22 activities, and we even bucket them into stages so we can really see the cost of the entire care cycle. So if you care about this, I'm sure many of you don't, but these are the equations a little bit more detailed in terms of how we detailed personnel and space costs. All right, so now to our results. So we included 39, there were 39 encounters altogether. We did have to stratify our cohort into group 1 and group 2 because we did really have 2 different types of behavioral health patients that came to our ED. So first we had patients that had not been seen in the community at all. They came straight from home and they required an ESP evaluation in the emergency department. And there's also a group about a little bit less than 1/3 that had already been seen by our crisis center at an outpatient clinic and were referred to the ED specifically to board. So when we weighted these 2 groups together, the length of stay of our typical behavioral health patient was 18 hours. And then the weighted cost per hour was $219. So the awesome thing about this method is that you can really divide your process. If you divide your process map appropriately, you can learn unique things about each process that wouldn't be apparent if you looked at it as a whole or by just each individual activity. So for instance, we learned that every patient that came to our ED requires medical clearance, and that's an obligatory cost of $372. And it's only a 1.5-hour process from the timestamp of arrival until medical clearance, but it actually required 2.4 hours of total work from the sitters to the nurses to the security guard coming to wand the patient, and from the nurse and the trainee or the physician and trainee to actually see the patient. The next is the wait time. We learned a lot about this, and the biggest lesson is essentially that if our response time from our ESP was able to be reduced to their actual contractual hourly response time, which is only really 1 hour, and they're going from 5.5 hours, we'd be able to save over $600,000 a year in savings. And another big thing about that is that the wait time was 1/3 of their entire length of stay and about 1/4 of the cost. So next is the ESP evaluation. And maybe this is surprising, maybe not, but this is the thing the patients come here for. And it's the shortest and the least expensive stage in our process. So the last is boarding. This is probably not surprising to folks that it's the most expensive and that sitters actually compose about 50% of the cost. And so there really, there really isn't much other resource going into the patients during this time. So these findings all reflect unique areas of improvement. So for example, the cost of medical clearance for each patient, regardless if they need, highlights regardless if they need to be cleared at the ED, reflects the burden of regulatory requirements. There's this big cost saving that we acknowledge from the wait time if we could decrease that. The ESP evaluation is really short and really inexpensive. And last, the cost per hour of boarding can be offered as a comparative tool when we look at other boarding options. So I just wanted to thank our entire research team. This was a wonderful project for me to do during my pre-med years and this year. And as I end this presentation, I really urge you to think back on this concept of quality and value, which is outcomes over cost. My goal is really to share with you how rich information we can gather about the cost by just taking the time to meticulously measure the care that we actually deliver to these patients. And with this data that we generated, this is just sort of like the start of what we can learn about our own care process. So thank you so much, and thanks for listening.
Thank you very much. That was an excellent presentation. There is one question in the chat from Dr. Boudreaux, which is, did you get reimbursement data to come up with the delta, i.e. total costs minus reimbursement?
So that's probably going to be paper number 2 or 3 out of this. We don't currently have the reimbursement costs, but in doing the lit search for this paper, really there is a psych observation billing code, but it's really only about I think it's like $56 to $107 per day, depending on the severity of the patient. And that was lobbied by ASAP a couple of years ago to make that happen. So one thing we do know is that if the physician spends 30 minutes with the patient or they're there for 3 days, the physician reimbursement is the same. So the physicians aren't getting reimbursed really anything differently if the patient's there for, 30 minutes or 3 days. The facilities cost might be a little bit different, but we highly suspect it's nowhere near the about $3,000 that it costs us to take care of these patients.
Yeah, it's an interesting situation, especially what we have here in Massachusetts. As you probably know, Marcella, and I know that Niels knows well, that the people who do these evaluations, who are part of these ESP services, which are essentially state run, and if they're doing it for the state insurances, they are the ones who actually bill and get reimbursed for the evaluation. It's not actually the hospital or the emergency department that gets paid for many of those evaluations. At least that's how it works in most of the EDs that I know of. So if you think about it, it's kind of interesting that the people getting reimbursed for the work of evaluating a patient aren't usually employed by, and therefore the ED doesn't benefit from that billing. And they're left with, though, the biggest burden of caring for the patient and of housing the patient and of sitting for the patient, et cetera. So if you looked at the total reimbursement of what's paid both to the ESP provider for doing that evaluation and the reimbursement for the actual care in the ED, which is usually probably going to be an E&M code kind of thing, so they're going to be a flat rate, it's going to be disproportionate in terms of who's getting paid best for the time they're putting in. The ESPs are actually making pretty good money for the time they're putting in, whereas the ED is really not. It's just kind of an interesting micro part of this whole reimbursement tangle as to who's getting paid to do what.
Right. Yeah. No, that's a great point. And if you think about the value equation, so outcomes over cost for boarding, for example, there is no outcome. The outcome is they're just sitting there. And so if they can sit there somewhere else, even in a place that's safer, like with ligature-free rooms, et cetera, and it's a decreased cost, we are technically improving the value for that patient population. If we're looking at value-based healthcare, that's all the rage, et cetera, we should be making decisions based off those findings.
I had a quick question, if you don't mind. Great presentation. Yeah, I was really enjoyed it. I was wondering, it was interesting to see that the children who were seen by ESP in the community had a longer stay, even though they had already done their eval, right? Does that suggest that there are people really getting diverted from the emergency department, and the people who are seeing the ESP in the community are the most severe?
So my understanding, again, as a first-year medical student, is that this group are potentially a little bit more acute because they stay a little bit longer. They are sent to the ED because they're essentially not able to go home to await inpatient treatment. So it's a smaller group just because I guess that's just how it is. But does that answer your question?
Yeah, it does. I think it does sort of like, it is a testament to the ESP service that they are fulfilling some of that diversion kind of function, and sort of avoiding the ED if possible.
Yeah, and one thing, we could do the study again and see if we would like to see the number of patients that are seen in the community go up, because that means our outpatient services are doing a really good job. We just don't want them coming to the ED, but I mean, unless they need to.
Right.
But so we were actually had talked about that, of maybe doing another study and looking at that comparison.
So that would be great. Thank you so much.
Yeah, thank you.
The irony of that will be an apparent increase in boarding average hours. So if you think about a thought experiment where, let's say 100% of the patients who would ultimately have been discharged from the emergency department are being seen in the community. So they're diverting all those lower risk patients, and you're left with only those who are going to be high risk and who are going to be admitted. So you have fewer total patients, but you have a higher average boarding because of the increased acuity. So somehow in your models, you have to, when you would have to take into consideration that whole spectrum of what's going on, because otherwise you might have a paradoxical conclusion that as we got better in the community with, enriching community resources, you saw an increase in boarding.
I see. Yeah, but if we have a decrease in patients, and if there's more boarding, but there's fewer patients, eventually, you have a cost per hour of boarding, it would be less if we use the ABC model. But you're right. That's a good thing to keep in mind.
Yeah.
Yeah. Thanks for the questions.
Any other questions? Would you talk briefly about what's changed in your own institution as a result of this work? What's been the impact?
Well, I do think that one of the most profound findings here was the fact that our current ESP service, we did find quite a considerable wait time, and that's a bit of a problem. And so again, I'm not, the person to disclose all of my hospital secrets, but we do think that there might be some change because of that, especially, if a certain group can't fulfill a certain contract, that's important to take a look at.
Great. All right. Any final comments? So I would like to thank the presenters who did a wonderful job across the board, and also the audience for their participation. And we look forward to future work in this area. There's obviously a lot to be accomplished. Thank you very much all.